afternoon, everyone. Welcome to Research Forum. We are so delighted to have all of you here today. Today, we have a special presentation on population and individualized health, or precision medicine. And this is going to be, I think, a really great topic for today. Many of you said that both population health and precision medicine were topics of great interest to you in our survey. So we're excited to have a talk that addresses both today. Our speaker today is a visiting professor from Johns Hopkins Bloomberg School of Public Health, where he's a professor of biostatistics and is also a professor of medicine in the School of Medicine. Dr. Scott Zeger served as the vice provost for research from 2008 to 2013 and was also interim provost of the university in 2009. He's co-authored 3 books, more than 200 scientific articles, and was the founding co-editor of the journal Biostatistics. Science Watch also identified him as one of the 25 most cited mathematical scientists. This is a cool fact. He has served as expert witness to the U.S. Department of Justice in several states in their civil suits against the tobacco industry. He's also been awarded an honorary doctorate from Lancaster University, is an elected member of the National Academy of Sciences Institute of Medicine, is a fellow of the American Statistical Association. So we are very honored to have him today, here with us today. Please join me in welcoming Dr. Scott Zeger.
Well, welcome everybody. It's a pleasure to be here, and I've had a wonderful visit. I came 2 nights ago and spent all day yesterday meeting mostly the younger faculty and students in the department, and it's an amazing department, and they're just exciting people, a lot of energy, a lot of great problems. So congratulations to Liz DeLong and to Duke for creating what's really one of the most vital centers of statistical and biomedical research. And this talk is really about how medicine founded, modern medicine founded 130 years ago or so in the United States on built on a foundation of the emerging biological sciences, is now at a crossroads where the founding scientists, which were largely biological in those days, are now required to be married to data sciences, because biological sciences themselves have become much more data intensive, and because we're capturing information now that we don't use at our own peril. So this talk is about a little bit of how to think about that problem, and the key idea is that what people call precision medicine isn't just genomic medicine. It really means using evidence in a scientific way to treat patients better. And I'm going to tell you about how we do that, and you're going to see that to do that you need population level data from which you can draw inferences about the particular patient for whom you're making a decision, with whom you're making a decision. And then the second thing I want to do is show you exactly how those decisions are informed by an evidence base. I know that this is a center of excellence of clinical trials research, and I want to start by saying that while I'm not going to talk about clinical trials, what I'm really talking about is how to get an information base in academic health centers in particular, so that clinical trials are much more routinely used, not only as a separate entity of research, but also as integrated into patient care. And I know Rob Califf here is one of the leading proponents for tearing down the wall that currently separates randomization from patient care, and I'm ready to run through the breach as soon as he knocks the wall down. So, and so that's really the overview. I want to apologize to the people who came yesterday. I had a little bit more of a technical talk yesterday. I'm going to use a couple of the same slides just to get it going, but then hopefully you'll see some new material. So can I advance this? Oh, thanks, great. Okay, so because I was told there would be a clinical audience to a certain extent, you guys were going to have exactly 30 minutes to get all this down, eat lunch, and then go back and do some surgery or something. I thought I would try to give my definition of precision medicine. It's not genomic medicine, it's more than that. And I thought I'd do it just in the context of what happens when a patient comes to sit with you. And so I wanted you to think just for a moment. I did this yesterday for those of you so you can now practice. I want you to think about a 40-year-old man, no family history of a particular disease. Because they turned 40, you told them to go get this test for a life-threatening disease. They did. They tested positive in the screening test, and they're very worried His wife is worried, his children are worried, and it took him 3 weeks to get into your office, and now you're sitting across from them. And what I want you to think about is the information that you're using to guide this person, right? You have 40 years, first time you had this a meeting about this disease, 40 years old, no family history, positive test. That's the data. And what do you do to answer the patient's questions? Well, what are the patient's questions? Doctor, what is wrong with me, and what should I do to get back to full health? And what you do is you remember that this test isn't a great test. You know, it's not very specific, and in particular, you think about this either quantitatively or qualitatively about this data set, this population data set in which 10,000 people took this test, and 1,000 of them tested positive. I've put the 1,000 in that blue square, and you can see that when we followed people forward with additional testing, a biopsy, for example, only 15 of the 1,000 who tested positive, who were like this man that's sitting across from you, actually had the disease. So you say to them, look, the chance you're having the disease is small, and the epidemiologists and statisticians know this is a positive predictive value. And we do this every day. We use it every day in clinical care. And this is what I would call precision medicine. So it's precise in the sense that there's a set of data that the patient's visit generates, or that your meeting with the patient generates. This is very simple, the simplest possible data. And then what you do as a clinician is you either can interpret the data in an entirely mechanistic way, that is to say you know the mechanisms entirely, and the data guide you to a particular treatment. And I'm going to argue that mechanism is just infinite population. You could think of it that way. Or what happens more often in medicine is that there's an empirical data experience about that situation, and you reference the patient against the data set that's sort of relevant to the advice you're going to provide or the decision you're going to make. And here we had a data set of 10,000 people on whom we knew something about the measurement error of this test, and you could then give a guidance to your patient. So that's precision medicine, and to actually make medicine even more precise, and I would like medicine to be both accurate and precise. So to make it even more precise, what we have to do is be able to do this kind of quantitative assessment of the risks and the risks and benefits of various treatment options in each of the major places when you and a patient sit to achieve a decision, right? And right now, except in some small numbers of cases, this is almost entirely done in a qualitative way, sort of with qualitative experience being brought to bear and intuition. And what's different now is that we're actually capturing information that we weren't capturing before, and we can actually begin to assemble these clinical cohorts that are relevant to each of the important decisions you make. And what I wanted to show you today, an example of that, and let me just say at Hopkins, we have decided that this is the future of Johns Hopkins medicine, and we are now building the infrastructure to do this often. And I'm not talking about making treatment decisions based upon this evidence. I'm talking about informing clinicians who, with their patients, will make clinical decisions, but fully informed by the relevant evidence, which hopefully in the future, as it has been in the past, will be from randomized controlled trials as often as possible. Okay, so in order to frame the problem, let me just say that here's a list of a couple of the kinds of questions that are typical of the ones that clinicians face every day. And the first one is just what was illustrated in the simple screening example. What is my health state? Right? What is the health state of the patient? And in many areas of medicine, you can't directly observe the state of health. You can only get measurements that are reflective of that state. But you sometimes want to know about not just the state, but the trajectory along which the patient is changing. And a key decision for clinicians is, given the health state, given the trajectory, and given the opportunities to intervene in various ways, which one is likely to provide the greatest benefit at the least risk. And then if you're running the health system and people are doing a good job with these, you want to then ask questions about whether across the system, the population of patients that you're responsible for are getting the optimal treatments as often as they should, and what the benefits to the health system as well as the patients are. So to summarize the talk, really, precision medicine is simply about informing each individual's decision by the relevant population evidence, right? You want to bring evidence to where the decision is being made, and that means that you have to reference that individual and the data for that individual against a population of people for whom who are like that person and for whom we know about the outcomes that they've achieved with various treatments. And ideally, those treatments in some place were randomized to patients. And then this notion of generating evidence from a relevant population, and then what we want to do is we want to make the population as precisely tuned to this patient as possible. I had three simple facts, 40 no family history positive tests, but what if I had also been able to have a genomic screen for a predisposition and some other markers? And what's exciting about our time is that those measures are now emerging at a very fast pace. But the way to get ready for that and a way to think about them is we're going to be doing what we've been doing always, the first step, but now being able to tailor the populations much more tightly to the person at hand. So I was told I had to ask you questions, and I tell you, Carolyn, who worked with me on this, she's amazing, so I did exactly, after I talked to her for a few minutes, I decided to do exactly what she told me to do. Good for you, Carolyn. And I've used the word evidence here, and the first question I have for you is, what do I mean by the word evidence? What is evidence? Now, how do they answer it? Do they do something?
Raise their hand.
Does anybody know what evidence is? Well, actually, don't answer that question. I'm going to tell you what evidence is. Oh, no, go ahead. I want to see somebody's opinion first. What's evidence? Do you have an opinion about what evidence is? Just shout it out, right? I waited to find somebody whose mouth was full of food, and then.
I guess a physical representation of what it is you're looking for.
Okay, great. One more. Who knows what evidence is? Go ahead.
Probability.
Probability is evidence. Okay, great. So let's talk about evidence. So I just want to make this concrete. I want to talk about the scientific method first. So I have a coin, and because evidence is used in the scientific method. So what's the scientific method? The scientific method is where we first do something that isn't scientific. We generate a set of hypotheses about the state of nature. So here's a coin, right? And the coin has two sides, and it has some number of heads on the coin, right? Is there anybody here who doesn't know about heads and tails? Okay, great. So it has some number of heads and some number of tails on this coin. Would you agree? That's a state of nature. Think of it as like the state of that patient who had tested positive, either has that disease or he doesn't. That's the state of nature, right? And we have hypotheses about the state of nature. Generating the hypotheses is not science, but it comes from experience. So how many people, how many people think there are no heads on this coin? Raise your hand. How many people think there's one head on this coin? Raise your hand. Okay, how many people think it's a two-headed coin? Raise your hand. Okay, so it's mostly one-headed coin, and there's one, sort of counterculture person here who's going to, okay, so those are three hypotheses, and I've called them H0, H1, H2. No heads, one heads, two heads, okay? And I elicited your prior beliefs. Those are not scientific, those are your beliefs, right? Most of you believe it's a one-headed coin. Where did you get that from? From your experience of coins, right? Okay, now what we do in science, this is now where the scientific method starts, we design an experiment that generates evidence that supports some of these hypotheses relative to others, right? And at this point, I need Carolyn to be my volunteer, so if you'd come right here. And I could just look at the coin, Carolyn could look at it, and we'd be done, right? That wouldn't be very interesting. You can't do that in most of your science. Like if you have a drug and you want to know what's the probability that the drug relieves a random patient's pain, right? You could have some belief about that. The set of possible hypotheses are all the real numbers. And what we do as scientists is we say that nature is likely to be a way that is consistent with the data we see. It would be silly to be a scientist, see a data set and say, oh, that data convinces me that nature is a way, in a particular state that would make the data impossible to have occurred, right? That would be unscientific. Okay, and the other thing I want to say about evidence is it's always relative, and it's what science generates. And this is now, so many of you now already knew where I was going. So the way you use the evidence is what's called Bayes' rule. And Bayes' rule simply says you have to start with some belief about the state of nature. And here I've got that belief. This is called the prior odds. Prior meaning before you did the experiment. And PH2 just means the probability it's a two-headed coin. And PH1 is the probability it's a one-headed coin, right? And I actually know something about your collective belief because one person said it was a two-headed coin and 60 said it was a zero-headed coin. So this number is 1 divided by 60, right? Which is saying it's probably we believe it's a one-headed coin. But now here is the likelihood. And this is called the likelihood ratio. It's the probability of seeing heads, 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 given it's a two-headed coin. What was that probability? Exactly. Divided by the probability of seeing heads, heads, heads if it was a one-headed coin, an eighth. And what's 1 divided by 1/8? Very good. Very good. And I've done this before, and they don't always get that one right. So it's your Duke affiliation. So whatever the prior odds were, 1 to 60, now we update the prior odds with the ratio of the likelihood by a factor 8. So now the probability of it being what we should believe if we're coherent people is that the chance it's two-headed, given you've seen heads, heads, head, divided by the chance it's one-headed, given you've seen heads, 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 is a 60th times 8, or 8/60ths, which is 4/30ths, which is 2/15ths, right? 2/15ths. Still, we believe now, in light of that data, the evidence from the experiment, that it's probably a fair coin, right? Agreed? Do you all agree? How many people think it's a two-headed coin? Raise your hand. How many people think it's, I got up to 3. That's pretty good. How many people think it's a one-headed coin? Okay, so that's about, right, it looked to be about 2/15ths. So come up here, because we have to get this on camera. All right, so do you want to come assist her, because she may lie now.
All right, here's one head.
Ta-da.
We shouldn't have trusted him. Two-headed.
Two-headed coin. Two-headed coin. Now, if I had time, let me tell you what I would do. Let me tell you what I would do. I have another quarter in my pocket. And how many heads on this quarter?
Well, this is South Dakota. There's actually technically 2 heads, but heads and tails.
Okay, and if I had time, I don't have time, but what I would do is I would do this. What am I doing? I'm changing your prior belief. I'm just going to take one of the coins at random, and I'm going to flip it 3 times. And I'm going to tell you, I'm going to get 3 heads in a row. Are you with me? Let's just suppose we did that. How many people think it's a two-headed coin? Raise your hand. Go ahead. For this coin, right? How many people think it's a one-headed coin? So there's more people think it's a two-headed coin than a one-headed coin. What changed? It was the same experiment and the same data. Heads, heads, heads. What changed in the second experiment? Up there in that formula, what changed? Your prior belief. Suddenly, you heard Liz saying, that it's not a representative coin, but she was running against what you were believing. You were believing it was just a random coin I took from my pocket, and so that this was really, very, very small, right? But then when I randomize, you'd say it's a 50-50 chance I got the two-headed coin, and so then 8 times 1 gives a factor 8, which means it has a 8/9 probability of being the two-headed coin. So the prior change. Science is not about the prior or the posterior. It's about the likelihood ratio. That's the evidence. And that's what you generate in your clinical trials. But now, medicine, unfortunately, isn't just science. Medicine is taking what we know from science and applying it to patients. And precision medicine is using Bayes' rule to do that, where we actually take what you, the clinician, believe about the likely causes or likely benefits of treatments, bring what relevant evidence there is available for that patient, and then be coherent in the treatment. Make decisions that are consistent with the probabilities. And we as time goes on and we generate more of this becomes really inconsequential to the analysis. So health systems have to now make it possible to begin to capture the relevant evidence in their practice, in their medical practice, and which hopefully will include lots of clinical trials, the way Google does or other companies do, and we'll be able to move forward and make medicine scientific. So let me now give you an example where we've done this. So we're trying to do this at Hopkins in lots of applications. Here's one application where we've gotten the furthest along. And it's an example where the clinical decisions are informed by data, and the data is getting fairly complex. Too complex for a clinician to integrate it and to make appropriate probability assessments on their own. What they can benefit from is a formal calculation that they're given and that they sit down with their patients and make decisions from, and I'll show that to you. So here's one of our doctors talking to one of our patients. This patient has prostate cancer. It's a low-grade prostate cancer. The initial Gleason score was a Gleason score of 6. And so, some doctors would take out this prostate. Many would choose to do some sort of active surveillance or watchful waiting. And I want to acknowledge that this work is from Bal Carter's practice and with postdoc Yates Coley. And here's the data that we have on this man. This isn't the first time he's come to see this doctor. And here are his prostate-specific antigen scores. And you can see they're trending up, and they've crossed a barrier of 4, which is thought to be an indicator of some concern. And he had his initial biopsy back here when he was 69 years old, and he had a Gleason score of 6. He subsequently has been in an active surveillance program at Hopkins, and he has had biopsies 2 years later and then every year thereafter. And partly the decision to do these biopsies is as a result of his concerns about his situation and his decision to not take any more aggressive intervention, but rather just to sit tight with the cancer. So these are the data, and the question then is, what's his probability of having, the state space here, the state that I'm interested in as a clinician is either that tumor is indolent, and by that I mean will do nothing for it and it will never affect the quality of his life, he'll never have a significant problem from the tumor, or the tumor is of the more aggressive kind that's likely to cause him, has the potential to metastasize and likely to cause him significant problems. And so we actually, the actual model that we use has 4 grades of cancer, not just 2, but I want to make it simple. So that corresponds to the 2 heads, indolent or aggressive tumor. So now, second question, and by the way, here are the error rates for the biopsy, just for those who want to use that in their calculation. So go ahead, you're the clinician. Oh, and by the way, here's 9 other patients who also have similar kind of data, and we actually took out all of their prostates at some point, and these 3 had aggressive tumors, and the others had indolent tumors when we actually did a full pathology. And now the question, I knew there was a question here. The question is, what's this man's chance of having an aggressive tumor that would indicate either prostatectomy or radiation treatment? And I think I have a multiple choice. Do I have multiple choice? Let me see. No, I don't. Okay. So you can guess anything. Someone take a guess. What's this man's... Are there any urologists in the room? Come on. You don't have to be embarrassed. It's okay. No urologist. How about a general internal medicine person? Huh? Okay. Well, how about a statistician? What's the probability of this? Look, there's his data. These are the guys that had significant tumors, aggressive tumors. Here's the error rates. What's his chance of having a aggressive tumor?
Fairly small.
Small.
The question I have is, it says no yes on the 3x3, and it says 6-7 on his scores.
Oh, this no means 6. It's the same.
Okay.
Yeah. Sorry. Thank you. Yeah, we changed the graph here. Yeah. Good eyes. Low risk of aggressive tumor.
Yeah.
Less than 1%.
Less than 5.
Less than 5. Okay. Who else has a guess? Anybody want to guess? How many people think they know what it is, they just don't want to say? Okay. Okay, so I'm not going to tell you what it is. You don't know, do you? No. I'm going to tell you what the algorithm says it is in just a second, though. And actually, we're going to get you to come up and just do the algorithm for us. So I'm going to skip this. So what I want to do now is I have like 3 more minutes. How much time do I have? No, I have no more time. Okay, just a few more minutes. I think I'm going to skip this, actually. I was going to show you some stuff. Actually, what I want to tell you, though, is that stuff I just skipped were just sort of a semantic way to make a picture of 3 ideas. The first idea is that there is these are three medical ideas, not statistical ideas, that there's a health state for a man with prostate cancer that changes over time, right? And the tumor doesn't get less, doesn't become more indolent, it's indolent and it can become more aggressive, right? But there's a true health state. And you don't get to observe that as a urologist. You get to take a biopsy and you get 0.5% of the tumor and you get to do pathology on those cells and you can see what you see. And you can take biomarker measures. We in these models use PSA, we use prostate density, and we use a couple of other factors. Turns out that some of the details, we've tried to use some of the details from the biopsy and they don't add any value to the prediction. You get to see this data, not the true state. And the data are meant to be used as a reflection for what the underlying true state is. That's really the clinical challenge, to use the relevant data to say what the state of the patient is. And so that the first thing in the model that I skipped is to say there is a state, there is data that reflects that state, and then the next thing is that there are interventions you do which change the state, right? And finally, which intervention you do is often driven by the measurements you make. That's all those slides said. And those slides were a sort of semantic way of representing relationships in such a way that we can push a button and a computer program gets generated that will take those data and predict what the state is, right? It isn't quite that simple. There's some people here who do this for a living, and they say, as long as you give me 6 months to push the button, we'll get the result. But where we're going to be in the future is that it'll happen much more rapidly, that you, clinicians and statisticians or computer scientists will work together, and in weeks you'll be able to put together these sorts of evaluations of the evidence and bring them to bear on the patient just using Bayes' rule. So here's the data again, and the model says he has an 8% chance of having an aggressive tumor, which was pretty good from the clinicians. Are you a clinician, I assume?
I'm a statistician.
Oh, even better.
I am of the age that I have friends who've had prostate cancer. So
Oh, you have a lot of prior probabilities? Yeah. Okay, good. And so what we've done is we built that model and we've tested it, and it seems to be both valid and it's not that precise. It's better than screen film mammography, but not as good as screen film mammography. It's better than screen film mammography for like a 50-year-old woman, not as good as screen film mammography for a 60-some-year-old woman. So it's sort of in that range. It's not great, but it's pretty good. And so what we've done, and the other thing we know is that in urology, the decision about whether to do an intervention or not, which intervention to do, is largely driven by what specialty the clinician has, right? So, and so if you do a lot of surgery and you're good at it, you tend to go that way. And if you're in the radiation oncology department, they tend to do that way. Not exactly, but there's a tendency, and there's evidence to this effect. And let me just tell you that of all the 180,000 prostate cancers, new prostate cancers each year in America, about 90,000 of them are indolent tumors in that range. Maybe it's a little less, 60,000. I don't remember the numbers exactly, but it's a big chunk of them are indolent, and a lot of those get taken out. So, for example, in the practice where we developed this, 40% of the tumors that were removed were indolent tumors, should have been left alone. And you say, well, might as well get it out. What's the difference? Well, because there are side effects from the surgery and radiation, which include incontinence and impotence and things like that, which is not a desirable outcome for the patient. So what we've done is we've taken this algorithm, we've validated it, and now we've put it into EPIC. So when the doctor sits with the patient, this is just a picture of the patient's data, and down here are the biopsy times, and they can hover over this, and it brings up the biopsy pathology and things if they want to discuss that. So this is just to discuss the data. And then we give them 2 numbers. The first number is that if you get your biopsy today, so first when they come to see us, they have to make a decision. I'm going to get another biopsy today, and biopsies are not nice either. Am I going to get a biopsy today? And then, given after that decision, do I want to stay in active surveillance or do I want to remove my prostate, basically at Hopkins? So the first thing we say is we also predict the probability of having a higher grade tumor on the biopsy. And for this particular man, it's only 3%. And I think many men would say in that case, talking to a doctor, let's wait till next year, right? And then the next thing we do is this is now with the four class grading system, grades 1 through 4 or 5. So these are the indolent. The yellow and blue are indolent, and the red is the lower risk, potentially aggressive tumor, and the blue is the one that's very dangerous. And so this is those probabilities for this man. And this is what we had done. This is just that 8% number. These two things add up to 8%. And we had just done this, and we had a patient group that met with us. We said, isn't this great? And they said, no, it's not enough. What we want to know is if we don't do anything now, and we're in each of these 4 categories, what's our 5 to 10 year risk of having various kinds of outcomes? And so this shows for the blue group that of 100 men who had their prostates surgically removed today, if 100 men like you had the prostate, what would be the outcomes? And all these guys would be cured. These guys would have PSA recurrence but no tumor recurrence, and these guys would have 1%, less than 1% would have a recurrent tumor. And we then do the same thing for doing nothing. So they wanted to see the chances for the 2 interventions. Okay. So let me just say that I'm just about done. So precision medicine, we have a precision medicine center of excellence in urology, and what they have done is charted all the decisions that get made from a pre-diagnosis patient through to a terminal patient, and we've just looked at this one, which is the decision to either stay in or leave active surveillance, and we're working on a second one here about what happens when somebody, anyway, let's not worry about that, but these are all the key decisions. And what I'm arguing is that we need to have the data set that each of those decisions are informed by the relevant database. I didn't tell you that the database we used for that active surveillance example was 1,500 men that we've been following for the last decade. We had a conversation yesterday about the idea of trying to build consortia where we have 1,500, you have 1,500, we get all 40,000, a big chunk of the ones that are new each year, and we begin to do this and get better algorithms and better decisions for our patients. I'm going to skip that. What I want to say is that to actually do this, so I've been trying to do this at my university for 5 years, and it's only in the last 18 months that we've made real progress. And here's just a little story about what you need. You need the leaders. I don't mean like, old people like me. I mean, like the CEO and the dean and the head of medicine and the chair of urology, people like that. They have to say that this is their priority. Because if they don't say it, it doesn't matter what researchers say. And actually, what they say at our place now is that we want to discover these, the evidence that's relevant, and we want to deliver it to the patients. And then you need to sort of make science-driven, data-driven medicine your priority. Not just the leaders, but you got to organize yourself to do this. And I think most of our centers have already done this. The only change is that it used to be largely bioscience, and now it's bioscience and data science. And so we have to bring both of them together into the practice of medicine. The current bioethical framework is not adequate to doing this, and I'll let you listen to Rob Califf's speeches about this. They're much more eloquent than I can do. We need to do like Google. We need to be randomizing our patients every time there's equipoise, even in patient care. And so we got to figure out how to do that in a responsible way for our patients. And then finally, and this is the one we're still struggling with at Hopkins, well, we're struggling with 3 and 4, but 4 in particular, you need to have a business model that when you don't do something, like you don't take out the prostate, our places make money taking out prostates. When you don't take out the prostate and you actually improve the outcome for that man, the people who build these systems have to be paid money for doing it. There have to be incentives in the system. This is only possible, these incentives only exist when there's an outcomes focus, not a delivery focus, and that, is also changing in our world. I want to first say that these are our leaders who have bought into this, and I thank them for that. There's a very important paper about the bioethical framework, which is in the Hastings Journal by Ruth Faden et al. And if you just quickly see, they have a framework now that says it's unethical to not learn in an academic health center, and so they have to balance that against the protecting the rights of the patient and new ways of thinking about that. And finally, I want to say we're building a system now that allows us to take many sources of data, public sources, Epic, and other things where evidence is being generated, bring it together, have IRB work on it along this automated way, create a safe research environment where we actually discover what works and doesn't, and then get it back into the workflow, either Epic or something next to Epic. So let me just close by saying precision medicine is simply informing each individual's decision by the relevant scientific evidence. And this is especially critical when the evidence is complex. If it's simple, you can look at it and figure out what to do. When it's complex, we need to aid our clinicians by these sorts of tools I've just illustrated. When we reference an individual against an otherwise similar subset, we want to make that subset as precisely tuned to that individual as possible. And this is really the role of genomics and other of the novel measurements that we're making. And finally, you can't do this unless your leaders say that it's your imperative. You have the infrastructure and data systems. We modernize our bioethical policies, and we have a patient-focused healthcare business model. So thank you very much.
So thank you, Dr. Zeger. We'll now move into the moderated discussion portion of today's session with Dr. Ben Goldstein, who is an assistant professor of biostatistics and bioinformatics and we're here with you today.
Well, thank you for a second talk and for a great two-day visit. Before opening up, I'll start with one question that I was thinking about. So you emphasize, and I agree with this idea that precision medicine is not about solely genomics. That precision medicine is not simply about genomics, but about how we use all the data to subsample down to the proper population. So my question is, on one hand, we're all humans, we all have the same plumbing internally, and we're very similar. On the other hand, we're all snowflakes, and we have our own genomics and our own histories and lifestyles and everything that make us all unique. How do we learn or determine where to stop subsampling?
He said he was going to outdo Oprah and the snowflake. That's it, I think. Yeah, so I think that it's especially important question for a clinical trials-oriented organization. The data that we need to rely on over the long run is clinical trials data, but clinical trials data should not be generated, written about, and then put in the closet. It has to be generated, written about, and made public. And Frank Rockhold here is the leader in thinking about this. It has to be made public in a way that I can get my hands on it when I'm trying to figure out where's the relevant evidence for whether prostatectomy is the right treatment for that man at that time. And it goes to not only estimating the average treatment effect, but also quantifying the heterogeneity in the treatment effect. And this is an issue we tend to power our trials to be as small as possible so that we can estimate the average treatment effect to a certain degree of precision. But what we really want to do is know what happens across patients. We want to quantify the evidence for the heterogeneity. Now, you can do that in clinical trials data, and we're learning how to do that much better than we used to. It has to become a part of every trial, not just an afterthought. And let me say that if you don't have that information, you should still do what I'm talking about. Because I would rather guide a patient about a treatment taking account of the estimated average treatment effect and what the clinician thinks is the heterogeneity among patients, and then give the patient some advice that says it could be helpful, but look, here's the chance it won't be helpful for you, because those treatments come with costs and with potential harms, so people should make decisions fully informed by the chance they're going to be benefited. And you'll see that in a lot of the treatments we use today, even though on average they're better, the heterogeneity is enough so that many people would not take that treatment as a result. We need to be honest about that. If we don't have scientific evidence, we need our best clinical minds to tell us what those values are. And then as one of the powerful things about these kinds of approaches is when you don't know something that you see is critical to the outcome, you design an experiment to go learn that thing, and it helps you focus where the next experiment should be. Yeah. Wayne. Yeah.
So I think I want to, my follow-up is on?
Yeah. You have to eat it.
I'm eating it. And
No.
My follow-up, and I think it might be continuing what you asked, because all through this I was wondering, how do you communicate uncertainty to patients? Because as you go smaller and smaller in your subsets, you're obviously adding uncertainty, and there's a trade-off. And I couldn't tell that in any of your tools for patients. I've always thought I don't know what they would do with the confidence interval. So how do you balance that issue?
Yeah, it's a great question. I want to say we have a patient panel that guides this work, and we asked them that question. We asked them how much more information. They want it all. And they said to us, if we don't know what that means, we want you to teach us what it means, because we want to know all the information. I want to tell you that they said, we don't want to make the decision. We want to make the decision with our doctor. And some clinicians worry that these things are going to interfere with their relationship. Actually, I want to also digress to say that Val Carter has been testing this in his clinic, has reported to me that he's so excited because it improves the relationship to his patients, and he's told them he's not going to spend only 15 minutes. He's told what are called the URVs or whatever the hell they're called, the RVU people, that he's not going to spend 15 because he needs more time, and the relationship's stronger. So, but in terms of communicating uncertainty, we have a group of people that are experts in this. They're not statisticians. I mean, some statisticians are good at this, but these are design people, and so we're working with them, and we have some ideas. And at first we thought this would only be something that would face the clinician. Clinician would explain it, but now we've decided it's going to go into MyChart, which is the name for our EPIC patient-focused thing. And so we're working on how to do that. I do want to go back to the smaller subsets, though, because there's two comments. The first is that as the subsets get smaller, we're going to know more about the mechanisms, I hope, and so we'll have better predictors. So I think smaller subsets will come with better predictors, I hope. First thing. And second thing is smaller, more narrowly defined subsets are also going to come with bigger consortia. So genomics is never going to have an impact, except for those few cases where we know the whole mechanism, but where you're actually trying to get risk profiles and so forth and just sort of do shading of treatment decisions, you're going to need big consortia to actually get the right predictors. And so this is about doing consortia. And the system that we've designed for Hopkins, we forced the people, the IT people, to make it all open source and all from the very beginning designed so that we can share it and share the data. It's all in the cloud, so we can all put data in the cloud. And the algorithms we're developing also can work on data sets that are kept separate from each other in case some institutions don't want their data to be merged. So I think consortia is partly the answer to the small strata.
Yeah, Raymond?
Okay, just follow up the question, similar question. It's that how do you define a similar individuals like me? Same thing that, and for a particular disease, maybe some factors matters, but the others do not. How do you take that into account to define the similar individuals just like me that matters for that particular disease I'm facing? To follow up to that, if we can figure out how to do this, to implement what you're talking about in the future, do you think we can treat ourselves? We don't need doctors anymore?
And just even to follow up on that kind of thing, is in the way that we learn that, is that a supervised learning problem, or is that an outside clinical expert solution of do we learn that way?
Right. So, there's a debate in statistical circles, and engineering circles, having to do with whether you can make better predictions with algorithms in which you just take the data and you tell the algorithm to go to work and you leave the experts out of the problem. So in speech translation and in some other problems, driverless cars, and some places, you actually do better when you get in speech translation, when you get the linguists to just go sit on the side and you let the algorithms work. In my opinion, this is just my opinion, medicine is not an example where that will be the case. And it goes to your question. So your question is, how do you know what otherwise similar means? And the answer is, you ask the clinician scientist whose ideas drive the formation of this model. That model I'm using is Bal Carter's reasoning about his urology patients. You ask him, what are the mechanisms that give rise to these outcomes, right? What causes that? And he tells you about the mechanism. He has a biomedical model that's the best one we currently have. And you ask him, what are the things you need to know when you're trying to decide whether to use, to stay in active surveillance or recommend active surveillance or go to prostatectomy. So you inquire of the medical experts, right? Medical experts. And you build a model that reflects their thinking about the problem. Is that the best model? Maybe, maybe not. But that answers the questions what otherwise similar means. It means the set of variables that are specific to the mechanisms giving rise to the disease in that particular place. And that's why this is a harder problem than speech translation, because there's thousands of unique medical problems, and the typical data set for each medical problem is 1,000 patients. If we do big consortia, we'll get 100,000 maybe, but for many, many problems, it's not like translation where we can take billions of copies of speech and do whatever you want. So that's where the otherwise similar comes from. Will we ever need physicians? Well, my answer suggests that we do, that what we're really doing is trying to capture their expertise, their understanding of the biomechanisms. If you want to now ask the question, will we know enough about the biomechanisms, and will we have precise enough data sets and algorithms that we eventually will not use physicians? Well, I wouldn't want a statistician taking my prostate out, so... And nor would I want a urologist building this model by himself. So we have a team, and teams are what's going to make the difference in the future.
Yeah, in the middle.
This is more of, I guess, like a health policy type approach, but you noted that there was a lot of some resistance in kind of scaling this to being implemented in practice. I was wondering if like CMS or Medicaid programs have reached out to you about like thinking about payment structures or how that translates to a health policy perspective? No.
No, CMS, I mean, maybe they reach out to some people. They never reach out to me. But we're actually not far enough along. So what we have now is an algorithm that is being tested in the clinic. And we're asking doctors to look at this and to use it with their patients as they see fit. We're collecting data about that. And what we're going to do after that is we're going to do a randomized trial to see whether using this procedure versus not using it actually reduces the fraction of people, increases the rate of people joining active surveillance, and reduces the rate of taking out indolent tumors. That's the question. And we're going to start that trial. We're going to have a debate about whether we can, quote, use it with clinicians looking at this information in the clinics before we report out from that bigger trial, because that's going to require time, but we haven't come to that decision yet. And the other thing we're doing is we're making this into a multi-institutional form. So one of the things that goes into this is information about the history of patients who show up at your place. So we have this algorithm. It works really well at Hopkins. We took it to the University of Washington. It didn't work nearly as well. And the reason it didn't is because their patient population is very different than our patient population. They have a much higher risk patient population. The people who come there and get into the urology practice are far along in their cancers. The ones who come to Hopkins are much earlier. And so the priors that we were using, the experience we were relying on and to make the calculation with the same likelihood function that the two place, well, it led to lower probabilities out there than they should have had. So what we had to do is get enough of a background at Washington so that we knew what the population was like. And then what we really need is we need many centers so that we can get a variance component across centers so that when we go into a new center, we know how cautious to be, and you can sort of take that into account in the predictions you make and then let it learn, and as it gets more information, it can be more precise.
Are you using the existing clinical data research networks like Mid-South or some of the Others that Pecoria sponsored?
So we're headed in that direction, but it's premature. So if when we get there, you guys can help us, we'll be calling. Let me just say before, the big issue for me right now is a business model. I mean, I do want to, two things are the big issue. One is I want it to be a consortium, and the second thing I want is I want a business model. Because if I spend a lot of time on this and advocate for this, and some finance guy, says you can't have this because the money goes back to the chairs, I mean, right now at Hopkins, there are 4 places the prostate patients show up: radiation oncology, radiology, urology, oncology. And wherever they show up is the person who basically tends to dominate the patient. Not exactly, but by and large, and they get the money. And there are deals between the health system and the chiefs of the departments. So I need a deal with the health system and the chief of the prostate cancer center of excellence. And as soon as that money starts coming here, then I know it's going to happen, and then I'll feel like I can go play golf
So
at
my
the
question-
Washington Duke. That was a beautiful golf course. Go ahead.
My question is from the perspective of a clinician, and it sounds like Dr. Carter has had a really good experience being able to ask for more time to spend with his patients. Most of us can't go to our chairs and business managers and demand that we get more time to go over a tool which I would love to use with my patients.
Right.
But what's been the experience of other providers, if you have any data so far? It sounds like maybe you're collecting it now.
Yeah, I wish I could tell you more about that, but we do have an excellent general internal medicine assistant professor for whom that is his question. And so what he's doing now is he's had about 100 patients with whom he's had 50 have used this and 50 not, and he's going and asking a series of questions, and also the clinicians about their experience about it. And my hope is that as we get more to a capitated care finance model, there'll be big savings by not taking out indolent tumors, right? It costs you $30,000, $40,000 to take out an indolent tumor, and it doesn't do the patient any good. In fact, it harms the patient. So there'll be money saved when we start showing that we don't take out indolent tumors, we only take out bad ones, or more often. And so that some of that money, as I said, has to be redirected to the people who do this, and part of that would be to spend more time, to pay the doctors time, to spend more time talking to a patient, to try to explain to them the probability so that they don't go get the thing out when it has a high probability of being indolent, right? Yeah.
One quick, knowing what you know, as a statistician, is there an age at which an asymptomatic man should have a PSA?
Oh, man. So is anybody who's on the big screening trials? Anybody here to answer that question? My own belief, having looked at this data, is I would delay the date of a PSA test as long as you can get away with your doctor not saying, why aren't you following my instructions? Yeah, like, I don't know, what's the first date they recommend? 50, I think now? I'm not going to say anything, because if Val Carter hears me, I'll be dead meat, and this is being recorded, right? But
That's a public health question.
it is totally a public health question, and I think your point is that we without thinking as carefully as we should, we make measurements that send people down roads that end up with bad outcomes, and that measurement had no negative impact on them itself, but it had headed them in a trajectory that was really dangerous. And so we have to be more careful about everything we measure. Yeah. I want to just say one other thing about Val Carter. A statistician's story, and I'm actually a statistician who had some positions where they treated me like an administrator, not a statistician, for a while. And so I got entree into some of the leadership meetings and things because of my administrative job. And so I knew these people, and I would be telling them these things. I thought they would be listening to me, and the leadership, they had other things. I was trying to change the engine on their 747 as they were flying it across the ocean. And they just said, I don't have time for that. Go away. But when Val Carter went there, once he figured all this out, he got really excited about this, and he actually knows. he believes in his heart he's going to provide better care to his patients. He's going to take out fewer indolent prostates, and he doesn't want to take them out. He feels badly every time he does. He goes to them, and they said, "Are you kidding me? That's great. Yeah, you need some money?" They gave him $300,000. So the message is for the statisticians here is you got to go to those meetings with your clinician colleagues, and preferably people who, I don't know. He's a North Carolina guy. No, I think he's from maybe South Carolina, but he's got a sort of draw. He's a good guy, and he charms them, and they listen. So don't go and just try to do it yourself. Go with somebody who they listen to.
And on that note, I want to thank Dr. Zeger for his wonderful 2 days visiting us. Thank you.
Right, thank you.